Hi guys, Dr. Dillard here. It is week 8. It is dermatology. It's winter 2021. Today we are going to talk not crazy deep, but we're going to get into basal cell carcinoma a little bit, and then we'll start talking about the more common nail conditions. Alright, so basal, now there's some sensitive pictures in here. I guess I should have warned ahead of time. This is a very destructive cancer. It is also the most common form of skin cancer. And it's not that it metastasizes and kills people quite as much as malignant melanoma, but it is very, very destructive. It has a tendency to burrow into the bone and destroy bone, especially on the face. So it's a very, very destructive cancer, and it's tough to get rid of. It likes to come back after it's been removed. And the lesions start out as kind of red little papules, or maybe plaques. The papules can coalesce together to form a plaque. But the key is they have an ulceration in the center. And they also have, as we'll see, pearly white lesions around the outside, kind of a pearly white ring with an ulcer in the middle is really, really a bad sign. Because there's an ulceration, it's not uncommon for this to bleed and then crust up and then bleed again. They can get absolutely huge and humongous, kind of a disturbing picture warning coming up next. So these are just some of the people. Now, the students ask me, why do they wait so long before they go to the doc? I have absolutely no idea. Some people can't afford doctors, and they just won't go until it looks like this. So yeah, don't go when it's like this, right? Kind of a no-brainer. That's where it's treatable. This is, what are you going to do with this? It's just going to, plastic surgeon will come in and do their best to try to reconstruct the face, but by this time it's probably metastatic. It's probably getting into the other organs as well. There has been a rise in the incidence rate across the world, about 10% rise, and we're not exactly sure what that story. There's a rise in a bunch of cancers, and we're not really understanding why. I don't know if it's something we're eating, it's the ozone thinning. There's a lot of theories, but we just don't know yet. The classification of basal cell carcinoma is a mess. There's about 26 subtypes that have been reported. Most authors agree on several different types we'll take a look at here in a second. Basal cell does not always appear on the skin. The other weird thing, most skin cancer shows up in heavily exposed skin regions that got hit with a lot of sun over many years, like the backs of your shoulders, the bridge of your nose, the pinna of the ear, the tips of the ears, the forearms, things like that. Basal cell carcinoma sometimes doesn't show up, or it can show up in regions that aren't heavily bombarded with skin, which is a little strange. Like the medial canthus of the eye is one place. Kind of the medial corner of the eye can start to show up. And there's that classic lesion, kind of red ulcerations with this little pearly border around the side. That's classic basal cell carcinoma. Did I miss the, where's the categorizations here? I guess we'll get to that in a minute. I thought they were right after, but anyway, let's keep pressing on here. Some fun facts. Let's see. Yeah, so 33% of them do not occur on the heavy skin, sun-exposed regions. Typically affects people over the age of 40. 85% of these do appear on the head and neck, though. The nose is the most common target. African Americans, this is one disease they don't seem to get. Very rare for African Americans to get basal cell carcinoma. Then Caucasians with fair skin and blonde hair or red hair and blue or green eyes are at greater risk. Just like all cancers, that's true for. UV radiation is still the main risk factor. So people who didn't put sunblock on their nose are at risk. And then once you've had basal cell carcinoma, as I said, it's hard to get rid of. There's actually a 10-fold risk of having it come back in 3 years, not 30 years, 3 years. So it does like to come back again. It can start on a place of like a burned area of the skin, or an area of skin trauma. It can start there. What's the pathophysiology behind this? It occurs secondary to mutations as, well, surprise, surprise, basal cells. Remember, they're stem cells that live in the stratum basale. They divide and create all the cells of the skin, including the keratinocytes. So these basal cells mutate and they divide into other basal cells. They still make keratinocytes as well, but the basal cells become immortal, and they go throughout the dermis and hypodermis, and as I said, they can penetrate bone. They also have a tremendous ability to penetrate endothelial tissue. They have great trouble. I was going to say that's not right. They have great trouble penetrating endothelial tissue around blood vessels, right? So they can't get into blood vessels. They don't like. The bottom line is they don't like to metastasize very much. A little deeper, UV radiation, especially UVB, mutates there's a mutation of a certain tumor suppressor gene called the patch suppressor gene, PTCH, has been associated with basal cell carcinoma. Here's the 4 major types. I knew they're in here somewhere. So most of the authors, the big books that I use are Fitzpatrick, Bologna, and Rook. They all agree on 3 of these forms. Remember, there's over 20 forms of this, 26 subtypes. So nodular basal cell carcinoma, superficial basal cell carcinoma, and morphiform basal cell carcinoma, sometimes called sclerosing basal cell carcinoma. We're not going to get into all the different types. We'll take a look at nodular. Pigmented is another fairly common one that Fitzpatrick talks about. But nodular, we'll talk about the most common form, and that's nodular. If you're going to get basal cell carcinoma, about 50% of the time it'll be a nodular basal cell carcinoma. This one is not super aggressive, meaning it can't get into blood vessels and lymph vessels, but it is incredibly destructive and can just eat tissue away. Like, it looks like you've had an accident here of the ear, but the cancer's literally eaten the ear away on this person. So it's very, very destructive. Basal cell is bad. Bad to the bone is how I remember it. Bad to the bone because it digs right into the bone. Can eat the zygomatic arch or zygomatic bone. It's bad to the bone. Classic presentation, again, we already said they're kind of red papules that coalesce, and they develop a ulcerated border, but they do have these pearly white lesions that are usually visible, and they often have telangiectasia, so that means you can see the blood vessel growth. The borders are said to be rolled sometimes, like somebody rolled up the borders. That's a strong clue as well. They often are pearly white and rolled, and we already talked about ulcers, so it can bleed. Let's take a look at some more. Here's a classic basal cell ulcerative or nodular type of basal cell carcinoma, and it's got a rolled. See how it's like somebody rolled up the border here, and it's pearly white on the border, and then we have a big ulceration in the center. That's a classic nodular basal cell carcinoma. Here's another one. This one doesn't have rolled borders, but you can see the telangiectasia in this one, and it's a nodule. So this is another nodule basal cell carcinoma. It's another one, kind of pearly white, kind of rolled borders. Looks like there was an ulceration that healed right here in the center. Classic basal cell carcinoma. This is a superficial type of basal cell carcinoma. These are more erythemic, raised patches. They are raised up a little bit, can be crusty. I'm not going to go crazy into that one because that one's not as common. What do you do for these things? Well, the less aggressive ones and the smaller ones can be removed by just cutting them out or surgical excision. The bigger ones, where people wait and wait and wait, those are going to be huge surgeries, and the plastic surgeon's going to have to come in. It's going to have to be reconstruction. And you have to do it because it'll eventually get into the blood and kill you. And again, those recurrent rates are just crazy. In this study, 5-year recurrence rates were 8.6% on the trunk, neck, and extremities. On the scalp and head, 5-year recurrence was 13%. On the nose, which is the most common place, the eyelids, chin, the jaw, and the ear, not the jog, 17%. So they like to come back, as we've said a couple times now. All right, so we'll leave basal cell carcinoma there because I got to keep moving. We got to get the nail in. I've learned you guys know nothing about nail anatomy, so I almost took this out, but I'll leave it in again. So the nails, you think of that hard thing on the kind of the dorsum of your distal phalanx or distal phalanges. That is only part of the nail. The nail apparatus is all of the parts of your nail together, and the three main parts are the nail plate, which we all know. If you've ripped off your nail, you've seen the nail bed underneath that gives support to the plate. And then the nail matrix is back farther toward the proximal part of the nail. And that's where all the stem cells, all the magic happens in this nail matrix. Right, so here's our first little drawing. And we can see the nail plate is right here. Nail plate, we'll learn, is actually double layer. There's 2 layers of cells that make this nail up. And that's because there's 2 regions of the matrix that secrete cells to make this thing. So we have a better picture than that, though. But that's the nail. Underneath the nail plate, we have the nail bed, which would be right here. It's all nail bed. So the plate sits on the nail bed. Underneath that, we have the matrix. The proximal matrix is here. Distal matrix is right about here. And really, the cartoon's off a little. This more distal matrix should be deeper. This one should be a little more superficial. Okay, subcutaneous. I'll stay on track with my slides here. So the nail plate, again, it's made of not keratinocytes, but onychocytes, which are similar to keratinocytes, only they have hard keratin in them, which the keratinocytes of the skin have soft keratin, where the onychocytes of the nail have, they still have some soft keratin. I think it's, I want to say it's 85% hard keratin for the nail, for these onychocytes. The proximal most part of the nail rests on the distal most part of the nail matrix. And some people have a little white covering over this region. I kind of drew one in here. See it right there? That's the lanula. It's called the lanula. Right. Said that already. And yep, here's just another artist's drawing of the nail. The proximal nail fold, is that what we're talking about here? So the distal and the majority of the nail plate rests on the nail bed. We kind of said that already. But the distal part of the nail plate and the nail bed support the nail plate. We said that already. The proximal nail matrix is covered by a proximal nail fold. I think that's the new thing here. So you can look at your own skin and you can see this. The cuticle, well, here's the nail fold. Comes out like that, and it does cover the distal or the proximal most portion of the nail plate. The nail matrix is underneath this proximal fold. And at the very end, you have this little part that's stuck to the nail plate, and that's called the cuticle or the eponychium. Right? What produces the nail plate anyway? Well, we said it's made of onychocytes, but the onychocytes come from the proximal and distal nail matrices, and they create a double layer nail. Proximal matrix produces the dorsal nail plate, and the distal matrix produces the ventral nail plate. If you destroy the matrix, so if you get an injury, like you get a nail driven into this area here, deep under there, that's the nail matrix. If you kill that area, your nail is done. You can't make nail. Here's a really nice picture showing the distal matrix, how it makes these this kind of bottom part of the nail plate, and then the proximal matrix puts another layer over the top of these onychocytes. So the nail plate is really double layered. Okay, onychocyte or onychocytic, or the birth of the nail plate. Onychocytic stem cells live in the matrix, and they divide and they push cells forward, just like the same with the stratum basale, how skin is made. And the newly onychocytes are pushed forward. I got a picture coming up here. I'll show you here in a second. Nail plate growth. So the nail grows about average about 2 millimeters per week. The toenails grow about 1 millimeter per week, and the fingernails grow about 3 millimeters per week. So if you lose your nail, it takes anywhere from 12 to 18 months to replace the nail. As long as you don't damage the matrix, you should be able to replace it. And the older you get, the slower the nail grows. As we said before, just like keratinocytes, onychocytes, the cells in the onychocytes, or the inside of an onychocyte is a cell, but the organelles within the onychocyte manufacture keratin. But this time, they make hard keratin, like hoofs and horns are made of. So 85% of your nail is made up of hard keratin. There's still some soft keratin, 15% is soft keratin. There's also a very intimate relationship between the nail apparatus and the distal phalanges. So much so that if you get a disease of one, it's going to often affect the other one. For example, psoriatic arthritis of the skin and the distal phalanges in the bone. So if you get psoriatic arthritis of bone, it can actually spill over into the skin and the nail plate itself, and leave a nail that's all pitted looking. And why is this? Well, unlike our skin, which has 3 layers, depending on what book you read, but there's the hypodermis, or there's the epidermis, the hypodermis, and the subcutaneous tissue is one of the many AKAs for that 3rd layer. The nail apparatus has no 3rd layer down. So there's not that extra layer to protect from bacteria. So you get an infection underneath your nail, it's really easy for it to go all the way down and cause osteomyelitis because you're missing that extra layer. Here's a patient with psoriatic arthritis and the classic kind of link sausage finger look. Very unusual, by the way, for a metacarpal phalangeal joint to have involvement. It's usually just the dip and the pip that are involved, in the proximal and distal phalanx, and the interphalanx are involved. Here's the classic, now we're not going to get too crazy into this, but here's the classic pencil in a cup that, if you haven't learned it, you will, but that interphalanx, or the intermediate phalanx, right? You have a proximal phalanx, you have an intermediate phalanx, and you have a distal phalanx here. The intermediate phalanx likes to erode into a point. That's said to look like a pencil. See how this one's eroded into a point? And then the distal phalanx, the base of it tends to widen. So it's classically said to be a pencil in a cup, as classic of psoriatic arthritis, and P's for pencil. So don't miss that one. And then we said if it's in the bone, it tends to spill over into the skin, or and in the skin in this part is the nail. And sure enough, this is a patient with psoriatic arthritis, pencil in a cup, and over the top you can see the nails are affected as well. Okay, there is a dermis underneath the nail bed. Lives a dermis, regular dermis, filled with blood vessels and nerve endings. It is again connected directly to the periosteum. There's no hypodermis in between the dermis, or that's subcutaneous tissue. There's many AKAs for that 3rd layer, right? Subcutaneous tissue, hypodermis, subcutaneous layer. There's a bunch of them. So again, there's no hypodermis. So here it is, and you can see nerves and blood vessels and everything right in that dermis there. Right, the nail bed itself, we haven't talked about that, but that's skin. It's a modified stratified squamous epithelium, just like our skin. Just like the esophagus is a modified stratified squamous tissue. Esophagus has 3 layers. The nail bed only has 2 layers. It just has the stratum basale where the stem cells are, and then there's a stratum spinosum. And yeah, that's the story with that. Sorry for the screaming kids. They like to sit out there and scream under my window. And there's nothing I can do about it, so I don't know if that's spilling onto the recording, but I apologize for that. All right, so let's get into the diseases now. So we have Melanonychia is our first disease, very common. I get questions, YouTube questions all the time about this. And it's a yellow streak in the nail, so let's see what it's all about. It's produced. Melanonychia. All right, so as the word applies, melano, that's melanocyte. So it involves melanocytes, but you're thinking, well, melanocytes, let's see, they're in the skin, they're in the stratum basale. They give us our skin color because they're injecting all of our keratinocytes with melanin. And that's true, but the nail plate doesn't have them. Well, it has them in the matrix. These melanocytes live in the matrix. But they're sleeping. They don't work. They don't inject the onychocytes with melanin normally, like the keratinocytes get injected. So they're dormant usually. Okay. But if they wake up for a bunch of reasons we'll look at, if they wake up, they're going to do what they usually do, and that's inject the onychocytes with melanin. And so in this case, so somewhere in this region, let's just make it really simple, one melanocyte woke up and the melanocyte started injecting its neighbors with keratin. So the onychocytes are getting melanin in them, which they're not supposed to have. And as they keep dividing by mitosis, this divides again and again and again. They all have this color in them. So you get this long colored streak from this activated melanocyte here. Okay, so the onychocytes are also being made, but these onychocytes, there's onychocytes here, but they have a melanocyte here, but it's sleeping, so it doesn't inject over here. Just all these guys are injected, and you get a colored streak in your nail from what? From melanocytes that have woken up, and they're supposed to be asleep in the region. Okay, so you get this brown or black or various shades of brown to black. You get this streak in your nail, and that's what Melanonychia is all about. And it's called melanocytic activation. So when the common word for this is, well, most of the time it's just called Melanonychia, this brown streak, but the official name is longitudinal melanonychia, when we know that the cause of this is something has woken up these melanocytes. Right, and there's a picture that what I just drew, only a lot better. Okay, there's another person with a melanonychia. Now this one you have to be careful of, because sometimes these melanocytes don't just wake up and start secreting melanin. Sometimes they wake up and secrete melanin, but they actually become cancerous. And when it gets into the nail fold here, the proximal fold, that's called a Hutchinson sign, and that's a sign of cancer. This is what killed Bob Marley right here. So that's not a good sign. It should never be in that proximal nail fold like that. Okay. All right, so longitudinal melanonychia again. The streaks can be thin, they can be thick, they can be variegated. And the thicker they get, the more worried you are that it's cancer, because sometimes it's really hard to tell the cancerous ones apart from the harmless ones. Okay, here's an African American who has one. I've seen, God, lots of students have showed me these things. Always scared about them when I go through this lecture. And as long as the and my disclaimer, always never try to diagnose yourself. You go to a dermatologist. Don't ever try to diagnose yourself. But I'd be worried if the skin had color changes here. That's Hutchinson sign. That would make me very nervous. Or if this was much bigger, if it was that big, I'd be nervous. And if it was changing, I'd be nervous that it was cancer. What causes melanonychia? So there's two processes that cause these melanocytes in the nail matrix to wake up and start secreting melanin. We can break it into functional melanocytic activation and melanocytic hyperplasia. So let's go through these. Functional melanonychia. This is the one we were just talking about. This is when dormant matrix melanocytes wake up and start injecting the adjacent leukocytes with melanin, and it makes them colored, and therefore you get this long streak, and that's longitudinal melanonychia. So longitudinal melanonychia is under the category functional melanonychia, and this is not dangerous at all. Right. The key is histologically. I mean, if it pops up out of the blue in somebody, you could still get a histological sample. You should still see the dermatologist. They can take a sample just to make sure. And when they take that sample, the melanocytes in the area will not be increased in number. So there will be a normal number of melanocytes throughout the matrix. That's the key, and that's the key that it's not dangerous. These melanocytes will not be cancerous, they'll not be dysplastic. They're just regular melanocytes which have woken up. And there's many causes that can wake these things up, and you should know these causes. It's almost a guaranteed question coming. Pregnancy, we don't understand the mechanism that pregnancy can pop these things out. Trauma, nail biters, a rough manicure, on your toes, tight-fitting shoes, or you get stepped on your toenail. These can all cause innocent functional melanonychia. The injury wakes it up. Addison's disease, HIV. African Americans, we don't know what it is, but they have a high number of these things. Radiation exposure, people having radiation therapy for cancer can get these drugs, chemotherapy drugs. Onychomycosis, which is a fungus we're going to talk about, can also set these things off. And sometimes they just pop up and there's no rhyme nor reason. Okay, African American with one. No reason. Doesn't wear tight-fitting shoes. Never had an accident. And it was just a functional melanonychia. There wasn't an increased number of melanocytes in the area. And in African Americans, they're super common. About greater than 90% of African Americans will have at least one of these functional melanonychia. Right, here's another one. Okay, not very scary looking. Another one might be scary looking, but to me it's not very scary looking because the proximal fold is fine. Okay, now we get into another category. This is melanocytic hyperplasia. So this is our second general category of melanonychia. And the melanocytes are turned on. They have to be turned on to make a pigmented nail. But not only are they turned on, there's too many of them. So the melanocytes are dividing too fast, faster than they should be. And some of them, they may or may not be dysplastic or cancerous. So if they can be just turned on in too many of them and be innocent looking, or they can be cancerous. So therefore there's two types of melanocytic hyperplasia. So there's benign, which we don't have to worry about, which is by far the most common. And then there's the bad one that's killed Bob Marley, malignant melanocytic hyperplasia. Some people call this one subungual melanoma. And that's, to make it even more confusing, subungual melanoma is under the subcategory of arcuolentiginous melanoma, which we've talked about last week, and I know this gets confusing. But back to the basics. These are hyperplastic melanocytic hyperplasia. And so when you do histological sample, you're going to find not only melanocytes that are turned on and working, but there's too many of them in the area, and that's the key. And then you have to look at the cells to see, are they normal looking cells? If they are normal looking, then it's just a benign melanocytic hyperplasia. They're usually either lentigo or nevi, and that's a mole. So moles are the same kind of category here. So you can get a mole in your matrix, a bunch of nevus cells, as we'll see, and they can make this. But the key is there's too many of them, but they're not dysplastic cells. The cells types are fine. If you do a biopsy and you find too many of the cells, but you look at the cell types and they're cancerous, they're immortal, they've detached from their basement membrane, then you got yourself malignant melanocytic hyperplasia. So let's go over it again because I know it's confusing. Benign melanocytic hyperplasia, the two subcategories. So there's lentigo of the nail. We've talked about lentigo, and it's the same thing. It's just an overabundance of hyperactive melanocytes, but instead of being in the stratum basale, this time of the skin, this time they're in the matrix, and they are injecting all the onychocytes with keratin. And so you get the streak because of these. There's no nest cells involved with these. Nest cells, when you hear nest cells, you think of a mole or a nevi, or nevus is singular. So no nest cells here. And then nevi of the nail is the same thing. There's too many of these melanocytes. They're activated, but they're not dysplastic. They are conjugated in these nests, just like a real mole would be. And so you would get the diagnosis of a nevi benign melanocytic hyperplasia. If it's just a lentiginous lesion, there's no nest, then it's a lentigo benign melanocytic hyperplasia. Got it? I know that's a tough one. And then the malignant melanocytic hyperplasia or subungual melanoma. This time, and I mean, the patient can all come in with this. This doesn't look cancerous to me, but you never know. You got to do a biopsy down here with a little needle, and you got to see what the melanocytes look like. And if they find the melanocytes mutated and dysplastic, well, that's a pre-subungual melanoma. And if they're cancerous, past dysplastic, if they have actually detached from the basement membrane, they're immortal, they're strange looking, they don't die, that's cancer. This one can get into the bloodstream quicker than the nodular type can. This is the one, again, that killed Bob Marley. And they like the thumb and the great toe and the index finger are their favorite targets. So melanocytic hyperplasia typically strikes in the 7th decade of life. 2% are Caucasians. Native Americans have problems with these. Look at that, 30% of the cases are of Native Americans. And then African Americans, people of color, Latinos, African Americans, Japanese, and Chinese, about 17% of the pie. So Caucasians usually don't get this problem, but Native Americans are really susceptible to this. And this has nothing to do with the sun, right? Because the matrix is completely protected from the sun. So here are some worry signs, because you're going to see melanonychia, longitudinal melanonychia, and they're going to say, do I need to go see a dermatologist? And just to protect that license of yours, you should say yes, especially if it just popped up out of the blue. But here's what makes you worried that it might be cancerous, subungual melanoma. They're 40 to 60 years of age. They're African American or Native American or Asian. This is Habif, according to Habif. The width or the breadth of the lesion is greater than 3 millimeters. There's a change. The patient noticed that this streak in the nail is getting wider and wider. That's a really bad sign, in fact. And this is a really bad sign if there's extension. If it extends up into the proximal nail fold, like I showed you earlier, that's a Hutchinson sign. It's almost always cancerous. And then if the family history is positive, does the patient's brother or grandfather or great-grandfather had subungual melanoma? That's a positive as well. And here is another Hutchinson sign, and you can see this is really aggressive. It's actually destroyed the nail. The onychocytes are so messed up. The nail area, this nail area is not super strong here. So this is subungual melanoma. But look for the Hutchinson sign here. Here's another one. You know, why they waited to come in so long, who knows? But this is in a Caucasian, so this is fairly rare. But Hutchinson sign, and this is subungual melanoma. And it's probably gotten loose into the liver or somewhere else. Here's some other. These are all Hutchinson signs. All no good. Some more bad signs. If the band is variegated, that's another risk factor, because normally it's black or brown or some tan or something. But if it's multicolored, that's not good. And again, if the size is the width of this band is getting thicker and thicker, that's also bad. So here's a variegated one. If you look at it under high-powered magnification, you can actually see looks like a rainbow there. That's subungual melanoma. You can also see it's gotten into that proximal nail fold. No good. That one's, you don't even need magnification. You can see that one's clearly variegated in another subungual melanoma. But remember, to make the diagnosis, you have to take a sample. You have to go see the melanocytes and see what they look like. Are they mutated? Are they in a nest? They're safe in a nest. Are they mutated, dysplastic, cancerous looking? Pathologist is going to make the diagnosis. Okay, so that's it. See y'all later.